So now it's my pleasure to ask Richard Ross to take the floor. Richard Ross has been involved at the University of Sheffield for a long time in designing and implementing new way of glucocorticoid replacement in CAH. And Richard is going to update us on where we stand in that respect. So Richard, the floor is yours.
Michel, thank you very much, and a massive credit and a big thank you to IFCA for not just only investing in research in CAH, but also promoting it from this excellent program. So my first slide, my disclosure slide. So I'm a professor of endocrinology at the University of Sheffield, but I'm also the founder and director in a company, Adrenal, which is developing new pharmacological treatments for congenital adrenal hyperplasia. So in my presentation, what I want to do initially is to talk about the circadian rhythm in healthy individuals and the impact of congenital adrenal hyperplasia on adrenal hormones. But I'll be brief about this because Lee Chan has given us a wonderful overview of that in her presentation. Then I'm going to talk about current glucocorticoid replacement regimens and the challenges, and then some new developments with modified release formulations that I've been working on. So we have a clock in the center of our brain which is set to local time, and most of us know the time pretty exactly. We wake up at the same time in the morning and we know the time during the day and the night. And this clock is very important for controlling our biological rhythms, and the most fundamental of which is the wake-sleep cycle. And the wake-sleep cycle, of course, is a feed-fast. We feed when we're awake and we're fasting when we're asleep. And of course, we need to control our metabolism to this cycle, and we do that through our hormones. And the most important hormone, or one of the key hormones in that, is cortisol. So as Lee has presented very briefly, the clock controls the hypothalamus, which stimulates the pituitary through CRF to produce ACTH. And then there is this negative feedback, as we've already described. And if you look at the graph on the right-hand side, this shows cortisol levels on the y-axis and time starting in the evening on the x-axis. What you can see is that our cortisol levels are actually really very low in the evening, and then they start to build from about 2 to 4 a.m. in the morning before we wake, to peak on waking to give us all that energy to go out for the day. We have small peaks at meal times, but the levels then decline over the day to fall to low levels. And you can see after about 7 o'clock in the evening, the levels are quite low. So a very distinct circadian rhythm. So what happens to adrenal steroidogenesis in classic CAH? Now, I won't go through this in detail because, as I say, Lee's already gone through it, but essentially there is a deficiency in the enzyme 21 hydroxylase, and therefore we can't produce aldosterone or cortisol. The feedback is gone, ACTH levels rise, and this drives things through, and as I'll discuss this in more, through 17-hydroxyprogesterone to androstenedione and then to adrenal androgens like testosterone. Interestingly, the actual classic pathway, as I described, is a bit downregulated in CAH. So I think to understand how we treat CAH and also then how we monitor CAH, we need to understand the pathways to androgen biosynthesis in CAH. And 17-hydroxyprogesterone plays a key role here. So what you can see in blue is that there are 3 pathways. So in the first pathway is the classic androgen biosynthetic pathway, which goes down through DHEA to androstenedione and then to testosterone and DHT. More recently, we've recognized there is another androgen pathway, the 11-oxygenated androgen pathway, which goes through androstenedione to the 11-oxygenated steroids, particularly 11-ketotestosterone, which is active at the androgen receptor. And in fetal life, there is another pathway which is active, which is called the alternative dihydrotestosterone, DHT biosynthetic pathway, which goes round through androsterone to DHT. Now, this pathway is not normally active or not significantly active in adults or children in healthy children, but when 17-hydroxyprogesterone levels are elevated, this pathway becomes active. And as I've already mentioned, there seems to be a downregulation of the pathway through DHEA, which we don't fully understand. But 17-hydroxyprogesterone then becomes key. And what you can see, and I've highlighted here in red, is that 17-hydroxyprogesterone is directing into the three pathways. It's directing into the classic pathway to androstenedione. Androstenedione can then go either to testosterone or through around the 11-oxygenator pathway. And the high 17-OHP levels then drive the alternative DHT biosynthetic pathway. So we have a challenge when we are treating CAH. So the goal of our treatment is to control adrenal androgens and replace glucocorticoid. And we know if we give sufficient glucocorticoid, as Heidi has already discussed, we can switch off ACTH and control the androgens, but we have the problem of glucocorticoid excess. The opposite is true. If we give deficient glucocorticoid, then we get excess androgens, all their problems. And as already been discussed, we recognize that current treatment there is an unmet need, there's an increased mortality, children are shorter than predicted, and there is impaired fertility in both men and women, and there is an increased cardiovascular risk, which is becoming more and more evident as people get older, assumed to be due to excess glucocorticoid treatment in earlier life. And the issue is illustrated here when we look at the treatment with oral hydrocortisone that doesn't mimic physiological cortisol levels. In the left-hand panel, you can see cortisol levels in the orange is the normal circadian rhythm of cortisol that I've shown. And then in blue, what happens if you take oral hydrocortisone 3 times a day? You wake up with a very low cortisol level, you take hydrocortisone, you get a peak, and then you get a trough before your next dose, and similarly in the evening. And if you look at the right-hand panel, this is data from Chamandari a number of years ago showing poorly controlled children on 3 times daily hydrocortisone. And this is showing 17-hydroxyprogesterone levels. And these levels are really very high in the morning. They fall during the day on hydrocortisone. But what you can see is at the time ACTH starts to rise overnight before the morning, you get very exaggerated 17-hydroxyprogesterone levels. And we recognize that despite many different treatment regimens, so there are, particularly in adults, there's really no consensus on treatment. Patients are treated 3 times daily, reverse circadian with a higher dose last thing at night, prednisolone last thing at night, dexamethasone last thing at night. Despite all these different treatment regimens, the biochemical control remains relatively poor. So from the 2 large studies, one at the NIH, a longitudinal study, one in the UK, studying over 200 patients each, if you looked at the 17-hydroxyprogesterone, and generally it's accepted that we want to keep this at least below 3 times the upper limit of normal, which is approximately 36 nanomoles per litre. Only about 50% were controlled in these studies. And the mean dose or median dose of hydrocortisone was around 30 milligrams a day. And that's in excess of that recommended for adrenal replacement, 15 to 25. And this is fairly universal in most of the cohort studies that have been published. So clinicians have taken a number of approaches, and there are a number of developments going on to try and address this overnight rise in ACTH, which drives adrenal androgens. So at the moment, we have longer-acting glucocorticoids such as prednisolone and dexamethasone. But the problem, as I show with these, they still don't control the morning rise. They're more potent, and that you're taking a non-physiological dose lasting at night when actually your cortisol levels are at their lowest. Continuous subcutaneous hydrocortisone infusions have been used effectively, and I'll discuss that briefly, but the problem is that they do cause some skin reactions. Plenodrin is a modified release formulation of hydrocortisone. It's a once daily dual release formulation of hydrocortisone, essentially provides once daily replacement of hydrocortisone during the day, but it doesn't replace the overnight rise in cortisol and therefore doesn't address the issues in CAH. Chronocor, which I've been working on, is a modified release formulation of hydrocortisone that does provide delayed and sustained absorption to replace that overnight rise in cortisol. So firstly, looking at twice daily prednisolone, which is quite a common regimen, and this is data published from the NIH. And if you look in the top graph, this shows on the left the ACTH levels, which in fact is the lower line, and on the right, the right y-axis is the prednisolone levels. And if you look at the prednisolone levels, which is the top line first, you can see after a dose last thing at night, your prednisolone levels peak at around 1 o'clock, when of course you don't normally have steroid, but they fall, and actually they fall into low levels by 5 or 7 o'clock in the morning. And you can see ACTH is still rising, and is an exaggerated rise going above the normal range. ACTH levels then fall again with the second dose of prednisolone. When we look at the androgen levels in these patients where this data is derived, it shows some very educational results, really. First of all, if you look at DHEA, you can see that DHEA is actually extremely low in this patient group. If we look in then the panel below this at 17-hydroxyprogesterone, what you can see is that 17-hydroxyprogesterone levels, and the dotted line is the optimal range, the 17-OHP is rising, and in a lot of patients are rising above the optimal range in the early hours of the morning. The same is seen for androstenedione, which levels rise. And then, very interestingly, androsterone, which is a marker of the alternative DHT pathway, is actually elevated throughout, but also rises in the morning. Continuous subcutaneous hydrocortisone has been used in patients with AI, but there's only been really one study in patients with CAH. And again, this was a study from the NIH by Debbie Merck. And she studied 8 poorly controlled CAH patients who had 1 or 2 or more comorbidities associated with their CAH. And what they did here was that they treated patients for 6 months with continuous subcutaneous infusion of hydrocortisone through an insulin pump. And you could see that they got better control of 17-OHP and androstenedione, as shown in the right-hand graphs. What you can see is the top line with the open symbols is before treatment, and you can see that, again, this rise in 17-OHP levels in the early morning to really very high levels. And then on the infusion, they're controlling, there's still a slight rise, but they're controlling the 17-OHP much better, although these levels are still pretty high. And you can see the same impact on androstenedione, where the infusion is again controlling the androstenedione now towards or in the reference range. And the important thing here in this study was that it was associated with some clinical benefit. 1 woman resumed her menses. 1 man had a reduction of testicular adrenal rest tissue. However, 5 out of the 8 did have skin infections at some point associated with the infusion site. So turning to Chronocort, this is a microparticulate formulation with delayed release through a pH coating. And if you look here, you can see some broken open capsules with what almost look like sand. And if you look at the bottom, you can see this one piece of sand, which is the drug, is basically has a inert core, the microcrystalline bead. This is coated with hydrocortisone. And then there's this delayed pH layer. And when you take food or anything or a medication into your stomach, the pH is usually less than 3. It's less than 5 or 6, even if you're taking acid inhibitors. As you pass through the gut, your pH rises to the last third of the small bowel to a pH of 6.8. So the way this medication works is to release hydrocortisone in the lower third of the small bowel. And on the right, you can see the study looking at the cortisol profile after twice daily Chronocort. In orange, you can see the normal curve, and you can see in blue a dose of Chronocort taken last thing at night. There's a delayed release, and then you get a rise which simulates similar to what you're seeing overnight to peak in the morning, where you take a second dose to fill in the day. In the phase 3 study, it did miss its primary endpoint, which was a big disappointment, although the drug actually worked. And the reason the trial failed its primary endpoint was because we did a very complicated analytical calculation, really. We did a mean standard deviation score over 24 hours on the logarithmically transformed data, and that really removed the impact that we saw in the morning. And this is the data after 6 months of Chronocort compared to standard treatment. So the standard treatment is in open symbols in the graph on the right, and what you can see once again is that there is an escape in the 17-OHP levels from around after 3 o'clock in the morning to peak on waking and then declining, but still being elevated in the morning. Whereas on Chronocort twice daily, the levels of 17-OHP were controlled throughout the 24 hours. And this was comparing to standard treatment, all different kinds, with actually the majority of patients were taking a reverse circadian dose of glucocorticoid last thing at night. And so the raw data actually showed a significant improvement in 17-OHP levels. And this is more evident when we just look at the Chronocort arm. So here is the patients looking at them on their standard treatment at baseline in the open white symbol, 17-OHP, the top graph. And what you can see, actually, compared to some of the other studies I presented, these patients were already quite well, they had levels which were towards the optimal range, although they rose out of the optimal range in this critical period in the early hours in the morning and on waking. What you can see on Chronocort, on an equivalent dose of hydrocortisone, that they had absolutely controlled 17-OHP throughout the 24 hours. And if we look at the androstenedione levels below, we can say the similar profile with a rise of androstenedione in the morning. But androstenedione levels were very low on a Chronocort therapy. And actually, this is a key learning that we have from this study, that when you control 17-OHP, your androstenedione levels are low because it's neither being generated from the 17-OHP excess, nor is it being generated from DHEA, which is low in 17-OHP, in CAH, sorry. So all the patients who've been on Chronocort were offered the opportunity to go into an extension trial and are now being treated, many of them, for over 2 years. So in the phase 3 trial, there was a blinded titrator who was titrating the dose according to the biochemical response. Of course, in the clinic, the clinicians titrated it more according to the needs of the patient. And what you can see in this right-hand panel is the 17-OHP level in the morning and the in black, and the hydrocortisone median dose in red on the right y-axis. And if you look to the left now, at the beginning of the study, before Chronocort, patients had a 17-OHP which was right at the top of the optimal range and often over it. During the phase 3 trial, the 005 trial, you can see that levels of 17-OHP dropped to very low levels, and the dose of hydrocortisone was increased from 25 to 30 milligrams. And then in the extension trial, the clinicians gradually reduced the dose of hydrocortisone so that you can see at 12 and 18 months, the median dose of hydrocortisone was 20 milligrams, which is an adult replacement dose of hydrocortisone, and the 17-OHP was still well controlled in the optimal range in 80% of patients. And importantly, the treatment with Chronocort has been associated with clinical benefit. 8 patients had restoration of their menses, and we've seen pregnancies in the patients, both the patients and their partners. So 4 women with CAH have got pregnant on Chronocort, and 4 female partners of men with CAH have got pregnant on when the male partner is taking Chronocort. And in one patient who had documented TARP, there was an improvement in the sperm count, which was very low at the beginning of treatment. Finally, in the phase 2 trial of Chronocort, we looked at the alternative and lemon-oxygenated androgen pathways, And this was done in the urine by Wibke et al. In Birmingham. And what you can see in the top panel here is the 17-hydroxyprogesterone metabolites at baseline, that's BL, and then day 4 of Chronocort, and then at 6 months. And you can see that there was a reduction in 17-hydroxyprogesterone metabolites. And then if we look at the alternative pathway, you can see a similar reduction, and the same for the 11-oxygenated androgen pathway. So what have we learned? Cortisol has a very distinct diurnal rhythm driven by ACTH. CAH patients have an exaggerated overnight rise in ACTH, generating a diurnal rhythm of 17-OHP. Normally, in normal health, 17-OHP has a very minimal rhythm. And it's the diurnal increased, exaggerated levels of 17-OHP which drives the excess adrenal androgens. Normalizing 17-OHP and CAH results in low androstenedione levels because it's neither being generated from 17-OHP or DHEA. And normalizing 17-OHP in CAH has the potential to improve health outcomes, as seen through restoration of menses and reduction in testicular adrenal rest tumors, both during continuous subcutaneous infusions and during Chronocort therapy. And I've just put here, as we've already discussed in this meeting, there are CRH antagonists, which may reduce glucocorticoid requirements in development. And of course, the excitement and funded by IFCA, which is, massive credit to them. Gene therapy, which would, of course, be the one therapy which could both replace glucocorticoid and restore androgen control. So I'd like to acknowledge, and I'd like to really say a big thank you to IFCA, because I think they've stimulated research in the whole community, and also promoting and bringing in patients and clinicians and experts from around the world to focus on this rare disease, and particularly for supporting my research, where they have supported us in the looking to develop a nasal emergency therapy for CAH. I'd like to also thank the patients and investigators who participated in our clinical trials, and particularly the investigators for our phase 3 clinical trial, who are listed on the right here. Thank you very much.
Thank you so much, Richard. So we are a little bit behind schedule, but I think it's extremely important to take 5 minutes for question, and I hand it over to Anna Biaison-Lobert.
Thank you, Richard, for this very interesting talk. Before I go to the chat, I have two brief questions. You've been, y'all have been treating patients for about 2 years with Chronocort. Would you care to tell us what are the side effects, or what is the, for instance, on metabolics or on obesity of patients under Chronocort? And the second question, very briefly, is what is the stress dose of Chronocort?
So in terms of safety, the safety really is similar to that of hydrocortisone. We're essentially using hydrocortisone. In the phase 3 trial, there were 3 adrenal crises in the patients on standard therapy. There were no adrenal crises on Chronocort. In the follow-up study, there's been approximately 6 crises per 100 patients a year, which is actually slightly less than that reported in most of the studies where people have been measuring adrenal crises over time. And of course, this is a monitored study, so we're really picking things up, and we have a fairly low criteria. I don't think I mean, apart from there was an increase in infections in the study overall, so a lot of infections. I think we're recognizing that people with adrenal insufficiency, but there wasn't any specific, there were no serious adverse events which were specific to Chronocort. So Chronocort is a delayed release formulation of hydrocortisone. So our recommendation is that if you're taking Chronocort, that if you have an intercurrent illness and you require stress dosing, you should take immediate release hydrocortisone according to the normal sick day rules.
Okay, great. There are 2 questions from the chat. The first one is when Chronocort will be authorized in France. I don't think you can, I don't know whether you can answer to that.
Chronocort has been approved by the EMA, and that happened earlier this month. So it will be available in Europe
soon. Maybe I can comment on that. For the people in France, it's a long process, because even if you have a European Union market authorization, then each country needs to discuss with the firm how it will go. And usually it takes a year between the technical committee and the economical committee. It's at least a year before it's actually marketed, when there is an agreement on the price, which is the very difficult step.
Thank you very much, Michel, and that very clearly stated. Yeah, so it's approved, and we need to discuss with each country in Europe, exactly as Michel said.
I have a question that I'm not sure I understand. One is it possible any long-term studies on fertility? I do understand this. Do you plan any long-term studies on fertility under Chronocort?
Well, I mean, we're obviously observing in the patients that we are doing in our extension study, we are observing fertility in Chronocort, and we're very open to doing long-term studies. Of course, we hope to make it available to all patients, as Michel's discussed. So, yes, absolutely. We're very enthusiastic, and certainly the data is very impressive. I mean, one thing to say about the cohort of patients that we studied were pretty well controlled when you compare them to some of the other publications that we've already discussed on this program. But despite that, Chronocort was really able to improve control. So the majority of patients, we had really controlled the 17-OHP very well. And I think that improves fertility. I mean, my own bias is that, I mean, and the evidence certainly Jerry Conway's presented is that in CAH, you really need to push down the progesterone, because otherwise you do get an unfavorable endometrial environment.
Can I ask about an update on the infant cohort for the pediatrician and the parents of young children with CAH? Where does that stand?
Yeah, so Infocort is currently marketed under the name Alkindi. So this is a microparticulate formulation of hydrocortisone available in low doses from 0.51 to and 5 milligrams, and it's going through the process. So it's available in some countries, Germany, but it's going through the process in other countries.
Thank you.
Is the last question maybe? There are several questions that I combine in one. In which countries is this treatment available?
So I firstly say, if anyone has further questions, then the Diurnal website, you can ask for information. But it's been approved in Europe. We are looking to get, because of Brexit, we get it approved separately in the UK, and so we will try and make it available to as many countries as we possibly can in the negotiation with the local authorities.
Thank you very much, Richard. For the sake of time, we should move on, and I want to thank both Richard for that wonderful update and based on physiopathological data, and Anna for moderating the session.